Okay, good afternoon, everybody, and welcome back. Post-lunch oncology session. I'll just let you settle down a little bit. So this session starts with a keynote lecture, and it gives me great pleasure to introduce Dr. Alex Snyder, who is an authority on all things related to biomarkers in oncology. Alex Snyder is the head of R&D at Generate Biomedicines, a biotechnology company that uses machine learning and protein engineering to create novel medicines. Prior to joining Generate in 2022, Dr. Snyder was a principal at biotech incubator Two River, following her role as an associate vice president and head of translational oncology at MSD. Alex received her medical degree and internal medicine training at the Icahn School of Medicine at Mount Sinai and Mount Sinai Hospital, followed by medical oncology fellowship at Memorial Sloan Kettering Cancer Center, where she was a federally funded investigator until transitioning to pharma in 2017. Alex continues to practice oncology as a clinical assistant professor of medicine at NYU and Bellevue Hospitals. And by the way, I forgot to introduce myself. I'm Dinesh Dialvis at Generate Biomedicines, and I'm co-chairing this together with
Lena Friberg from Uppsala University.
Okay. So on that note, I'd like to let Alex Snyder over.
Great, thanks so much, Dinesh, for the kind introduction. It's just so lovely to be here. I realize I have a challenge ahead of me, which is that you all just ate lunch, and so now would be an appropriate time for a siesta. But instead, I'm going to talk to you about a field that I think is really coming into its own, which is the field of circulating tumor DNA and what its role is in oncology drug development and maybe going forward. These are my disclosures. One disclosure I'll also add, which Dinesh alluded to, is that I am not a pharmacometrician. I'm a simple clinician, and I've learned many things about pharmacometrics from Dinesh and other colleagues, and have developed a tremendous respect for and indeed reliance on the type of work that's done by all of you. So today I'll start by defining circulating tumor DNA and the methods with which it can be measured. And then I'll spend the bulk of the time talking about applications. I'll briefly touch on patient selection, and then I'll really focus on longitudinal monitoring, which I think is probably of more interest to this audience, particularly in the adjuvant and metastatic settings. So first, to get on the same page about definitions, because sometimes language is thrown around in this field that can be a bit confusing. So cell-free DNA is any DNA detected in the plasma. And in humans, this primarily comes from the hematopoietic system, especially lymphocytes. This is the majority of cell-free DNA in the blood. The circulating tumor DNA fraction is the tiny fraction of the total cell-free DNA that actually comes from the tumor. And indeed, over the past 20 years, the initial challenge was actually just distinguishing the circulating tumor proportion from the rest of the cell-free DNA. Indeed, that remains a challenge, and I'll dig into it a little more as I go through specific examples. One of the main benefits of circulating tumor DNA is that collecting it is relatively non-invasive. It just engenders a blood draw, and it can tell you about two broad things. One is the disease state, i.e. the genetic lesions that a tumor may have, and the other is that it serves as a proxy for disease burden, which itself leads to many of its applications. The main categories of use at the moment for circulating tumor DNA are patient selection, screening for cancer, and longitudinal monitoring, and I'll focus on the first and third of those today. It's important to note as we read studies about circulating tumor DNA that the characteristics of the assays that we use for the applications differ, and I'll go into that in more detail. Finally, I'll note that a perhaps little known fact is that a very significant proportion of patients actually don't have sufficient tissue for biopsy. Depending on the study, up to 20 to 50% of patients don't have tissue for molecular profiling. So in addition to the applications I've mentioned, it really does serve an unmet need. If you look at the figure on the left, you see the continuum of the cancer journey and the different stages in that journey where circulating tumor DNA can be potentially applied. So as you see on the far left, in the case of clinically undetectable disease, there are now assays being developed that can indeed detect that disease. Once the disease is detected, circulating tumor DNA can help characterize it. After surgery, and this is something I'll go into in more detail, circulating tumor DNA assays can be used to look at minimal residual disease, or MRD, to detect which patients are at highest risk for recurrence and potentially inform interventions at that time. Moving over to the right, the pink section, in the setting of metastatic disease, where disease is detectable, the uses of circulating tumor DNA change. So this is where selection of therapy selection of targeted therapy can be informed by ctDNA. And then from there, responses can be monitored. And again, I'll get into all of this in more detail. So a few words about methods. I've divided the applications of ctDNA in the blue box on the right. On the left are images of the different aspects of ctDNA that can be assayed. So for patient selection, where you're looking for particular genomic alterations, typically tumor-free assays can be used. In other words, all the patient needs is a blood draw. You don't need to also have a piece of their tumor. You can think of this as the blood equivalent of something like the Foundation Medicine panel. Some panels use matched normal DNA also from the blood to subtract out any mutations that may be found in the normal lymphocytes, and some don't. A second application of ctDNA is for monitoring of diagnosed disease, particularly in the metastatic setting. And these assays typically are tumor-informed, meaning you need the baseline tumor tissue and a blood test developed for a particular patient. These assays are bespoke, meaning they're designed on a patient-specific basis. Sometimes we also use these assays in the adjuvant setting. Now, for screening in the adjuvant setting, as you can imagine, the quantity of ctDNA in the blood is extremely low. And the most important thing is to discern whether it's there or not there, rather than focusing on the nature of the ctDNA that is there. So as a result, as you'll see in the two blue boxes, patterns within the ctDNA are looked at. So as it turns out, the methylation pattern of circulating ctDNA is quite different from the methylation pattern of normal cell-free DNA. So the assays used for screening and some of the assays used in the adjuvant setting rely on these characteristics of the ctDNA to say present or not present. Others use both those characteristics and genomics, depending on which assay you're talking about. So one more word on the challenges and potential resolutions in ctDNA as a whole before I move into particular examples. So I would say the biggest issue that we have in the patient selection space is tumor plasma concordance. In other words, if you were to look at a biopsy of the tumor and you were to look at your ctDNA assays, are they picking up the same mutations? In many cases, the answer is actually no. And obviously that causes a problem when you're trying to make treatment decisions based on the results. So there have been studies of this. It is a situation that is getting better, but it is something to be aware of if you use these assays. I'll also mention the second bullet is an important one, which is about the amount of ctDNA that a given tumor sheds. So if you look at studies from even 5 years ago, there was a wide range between tumors where you could detect ctDNA and those where you couldn't. Increasingly sensitive assays are being developed, so this issue is actually lessening in the metastatic setting. The next issue is clonal hematopoiesis, which I referenced briefly a moment ago. This is when regular healthy people can develop single nucleotide variants or mutations in their lymphocytes. This actually happens in approximately 25% of people age 65 and older, and it becomes more common as people get older. So if you have an assay that doesn't use normal matched DNA, it can be difficult sometimes to tell whether a mutation is actually from the ctDNA or it's just something that happened normally in that patient. In many cases, those mutations are quite characteristic of the hematopoietic compartment, such as mutations in genes like TET2, but there can be cases where actually a lymphocyte will have a mutation in P53 or KRAS, something that you would think of classically as a tumor-related mutation. So that is why some tests use matched normal blood, others use computational algorithms to try to subtract sort of theorized normal mutations. Another issue for the adjuvant setting is fluctuations in DNA post-surgery. So some patients experience kind of a burst of ctDNA after their surgery. So if you take the test too early, you may actually get a false impression of their degree of risk. It seems like 4 weeks is sort of the magic time point where things settle down and the assessment of risk actually becomes more reliable, and I'll show you some examples of that. This issue of physiologic state is one that was written about a lot initially, but doesn't seem to be as much of a problem as people worried about. The theoretical worry was if someone had a fever or if they had just exercised, would their ctDNA level be substantially different? That hasn't really panned out to be a severe problem, although it is one in theory. And then the second one still remains somewhat of an issue, this issue that different histologic subtypes release different amounts of ctDNA, but again, the increasingly sensitive tests are addressing that. I think to this crowd, I don't need to explain why sensitivity and specificity are so important, so I'll go right over that. I think this one of all the problems is the biggest challenge, and you'll see this as I go through specific examples. As I show you these examples, almost every one uses a different test than the others. So you'll see that the results are thematically consistent, but how can you actually compare across platforms? There is realization in the field that this is a big problem, and so there are organizations that are pulling together folks from academia, industry, and the test makers to try and standardize these issues. But I would say of all these challenges, that remains the biggest challenge. So let me transition now into talking about applications. Patient selection I'll just touch on very briefly. It is incredible to me how quickly ctDNA has moved into standard of care for patient selection. So in lung cancers, it is FDA approved to test for mutations in EGFR, MET, ROS1, ALK, HER2, and KRAS. In breast cancer, PIK3CA and ESR1. Across cancers, NTRK fusions, and in some situations for ovarian and breast cancers, BRCA1 and 2 alterations. Importantly, these tests are not approved across the board. They're approved associated with a specific indication and drug. So if you're developing a drug and you want to use one of these, obviously if it's already on the list, the barrier to entry is lower, but I want to be clear that you do need to work on the approval for the test along with the approval for the drug. I'll also add that in theory, patients who have a negative test by liquid biopsy are intended to undergo tissue testing. In many cases, that doesn't happen because the reason they had the liquid biopsy in the first place was because they didn't have tumor tissue. Additionally, the results often come back faster just in a regular hospital environment, but from a regulatory perspective, that is what is supposed to happen. So with that being said, let me move into longitudinal monitoring, which I think is probably of more interest to this audience. So on the left, this is a graphic that again focuses on the different applications of ctDNA during the trajectory of cancer. What I want to focus on first is the little hump after surgery, where we're detecting minimal residual disease. So as I mentioned briefly earlier, minimal residual disease refers to persistent cancer after treatment, for example, surgery and/or adjuvant chemotherapy, that cannot be detected with imaging, i.e. is interpreted as occult metastatic disease. Because ctDNA has a fairly short half-life, its dynamics can be used to assess disease burden in real time, and this may ultimately inform treatment decisions, although I will note that it is not standard of care yet in any solid tumor. That being said, it is standard of care actually in a couple of liquid tumors, and indeed the ctDNA field in solid tumors is looking to what liquid tumors did to inform our path forward. So assessment of minimal residual disease is FDA approved for ALL and multiple myeloma using an assay called clonoSEQ, which detects MRD at levels below 1 in a million cells. And initially, retrospective studies and then studies that used this prospectively showed that MRD by clonoSEQ correlates with event-free survival in ALL and progression-free and disease-free survival in multiple myeloma. And the FDA has agreed to use this as a surrogate endpoint. It is also being used as a primary endpoint, for example, in a CLL study called Cristallo. So the point is the precedent for the use of MRD in a regulatory setting is there in heme, it's not yet there in solid tumors. So on this slide, I've conveyed several of the studies that demonstrate how the level of ctDNA, or the presence or absence, correlates with recurrence-free survival across several solid tumors. So the top 2 studies in CRC are in stage 2 and stage 2 through 4 CRC, and you can see the relative sensitivity to relapse and the average lead time below each listed study. As I noted before, each of these studies used a different assay. These 2 both used tumor-informed assays, meaning the whole exome sequencing was done of the baseline tumor, and then a PCR assay of 15 or 16 genes that were particular to that patient were tracked in the blood over time. If you go down now to the breast cancer studies, similar assays, i.e. the way the assay was designed was the same, but they were actually different assays for those 2 studies. And again, you can see the sensitivity to relapse and the average lead time. Something I want to point out about the average lead time is this is something that really has differed from study to study, and so I don't think the field has sorted out yet what lead time really means. Because as you can imagine, if you use a much more sensitive assay, you're likely to have a longer lead time because you'll find ctDNA in the blood when there's less of it. Where this is particularly relevant to breast cancer is, as you know, there are several subtypes. Both of these studies grouped all those subtypes together and also looked at them separately. In the left-hand study, the lead time was about the same, 10 to 11 months in each subtype. But in the right-hand study, the lead time for ER-positive breast cancer was much longer than the lead time for the more aggressive HER2-positive and triple-negative breast cancers. This may be a reflection of tumor biology. It may be a reflection of a test. It may be a reflection of both. Going now to the upper right-hand side, this study used yet a different assay called CAPSEQ, developed out of Stanford. That one is not tumor-informed, and it had a very good sensitivity to relapse, but quite a short lead time, the difference of just 4 months. Again, is this because the assay is less sensitive because it's not tumor-informed, or is it because lung cancer is more aggressive and therefore the time between ctDNA and detectable cancer on scan is shorter due to disease biology? Finally, the bladder cancer study, again, had a very high sensitivity, but again, a very short lead time and used yet a different assay. So the take-home point from this slide is that MRD reliably distinguishes those patients who are going to have a lesser likelihood of relapse from those with a higher likelihood of relapse, but different assays have different degrees of lead time for the same clinical setting or a similar clinical setting. I want to dive into one of those studies a little bit more deeply, and that's the one that was on the top left, the TIE study. So the left-hand graph is one that you saw on the previous slide, which distinguishes outcomes by postoperative ctDNA positive or negative in stage 2 colon cancer patients. The graph on the right shows the division of the curves when you just use clinical risk scores. And the factors that go into the clinical risk scores are listed below. So T4, lymph node positivity, lymphovascular invasion, and differentiation. Those are the classically used prognostic factors. And what you can see is that ctDNA positivity or negativity distinguishes the prognostic effect much better than our classically used variables. There have been other studies that have indicated the same thing. So if I were a betting woman, I would say that the most likely early use of MRD detection will be in colorectal cancer. So what I've shown you so far is simply prognostic, right? If you're ctDNA positive, you're likely to do worse, unfortunately, than ctDNA negative. But is there anything else that we can do with this information? Can we actually use these data to de-escalate in patients who are low risk and escalate in patients who are high risk? And the data seem to be pointing toward the answer being yes. The other question is, can we think about ctDNA over time as a potential surrogate endpoint? So let's first talk about the idea of using ctDNA to inform treatment. So this study, IMvigor10, is a study, it was a randomized trial of atezolizumab versus observation in high-risk muscle-invasive bladder cancer. And a pre-specified exploratory analysis using ctDNA was performed. If you look at the graph on the right, the top two lightly shaded lines are patients who are ctDNA negative. The blue line are those who got atezo, the green are those who were observed. As you can see, there's absolutely no difference there. However, when you look at the ctDNA positive curves, the darker ones that are below, you can see that the benefit of treatment seemed to fall with those patients who were ctDNA positive rather than ctDNA negative. Let's go to a different setting. This is an observational study called Galaxy of patients with high-risk stage 2 and stage 3 colorectal cancer. For those who aren't in the colorectal cancer space, a real issue in colorectal cancer is who should get adjuvant therapy. In stage 2, it's particularly hard to discern the risk-benefit ratio there. So the patients shown on this slide had their ctDNA measured at 4 weeks post-op. And what you see is those who are MRD negative, who had no detectable ctDNA after surgery, demonstrated no significant benefit from adjuvant chemotherapy. And the chemotherapy used in this setting is quite toxic. I mean, it would be fantastic to be able to spare such patients. However, when you look at the ctDNA positive patients, again, same time point, 4 weeks post-op, irrespective of stage, you see that the curves separate very clearly, where those who got adjuvant chemotherapy, which is abbreviated ACT and shown in green, really did benefit from the adjuvant chemotherapy relative to observation. So I think those two slides don't conclusively show, but suggest that patients in the adjuvant setting who are MRD positive are more likely to benefit from adjuvant systemic therapy. Now, what about ctDNA during the course of treatment? Does that tell us anything? So this is, again, a study in the adjuvant setting, and if you look at the labels, negative, negative, positive, negative, et cetera, what that's meant to convey is the patient's ctDNA status 4 weeks post-surgery and their status 12 weeks post-surgery. And what you see in the green line is those patients whose blood was negative and remained negative did incredibly well with 92% 18 months disease-free survival. Those patients who had ctDNA and then cleared it also did really quite well with an 81% 18 months disease-free survival. So those are the patients who are really, really benefiting most from the therapy. Unfortunately, the two lines in blue show those patients who tested negative and then converted to positive, and those who started positive and stayed positive. And as you can see, those patients are really doing much worse. Glass half empty interpretation is just that. Glass half full is now we know whose treatments we really need to work on to improve outcomes in this population. Let's shift now to the metastatic setting. And here is where the field is in its most exploratory and I think very exciting setting. So can we use ctDNA, especially early on treatment ctDNA, to predict longer term outcomes and or to enable earlier assessment of drug efficacy? And I think that the arrow is pointing in the direction of yes, although again, data still needs to be collected, particularly in different disease settings. So this was a phase 2 study called INSPIRE of 94 patients with various different solid tumors who were treated with pembrolizumab. The vast majority had ctDNA detectable at baseline, supporting the point that I was making that the modern assays are really doing a much better job of catching everybody with metastatic disease. And here's where you see the progression-free survival at week 6 based on ctDNA level. And what you see is that those patients who had a decrease at 6 weeks relative to baseline did much better than those who did not. Another issue which is unresolved in this field is, should you be measuring clearance versus not clearance, or does a decrease without clearance actually mean something? So these are data from the same study I just showed you, and what you see is those patients with total clearance of ctDNA in the green line do exceptionally well. If you look at the months on treatment, we're talking 3 years there, and these are patients with multiply treated metastatic disease. Importantly, if you look at those patients in the dark blue line who don't have clearance but still have a decrease from baseline, those patients still do much better than those who have an increase from baseline. So with a 23.8-month overall survival relative to 13.7. So I would argue on this basis that measuring the level of ctDNA matters, that clearance is fantastic, but even those patients who have a decrease in their level still are likely to do better. And I'll note again, this is overall survival. It's not a randomized study, so it's definitely not the final word, but it's an arrow in the direction we would hypothesize. This is a different study, again, a different assay. You're hearing a theme here. This is a study of non-small cell lung cancer patients, and the assay tracked driver mutations. And in green, what you can see is the change in blood ctDNA levels, and in gray, the change in tumor size based on imaging. And interestingly, the drop in ctDNA in those patients who eventually had a radiographic response came a median of 24 weeks before the radiographic change. The point, therefore, is that these data really gave a hint of who would respond down the road. I think for us, many of us who are in the early oncology space, these data could therefore start giving us an early sense of what is going on in these patients. In another study of patients with uveal melanoma treated with the T-cell engager tebentafusp, they looked at ctDNA levels along the range of the study. For those who aren't familiar with this study, something that was remarkable about it was the response rate was really not very good in the control versus interventional arm, but the overall survival was meaningfully different. And so ctDNA, interestingly, actually gives hints to overall survival in this study. So the upper left graph is a waterfall plot, but of ctDNA rather than radiographic response. The lower graph shows the correlation between ctDNA at week 9 with a hazard ratio for death, so R-squared of 0.9. When you then look at survival, again, those who cleared their ctDNA did extremely well relative to those who did not. So that is, I showed you before, the lower graph gets at the second question of, do levels matter? And again, clearance is definitely better, but if you look at the blue line, these are patients who had progressive disease radiographically, but had a decrease in their ctDNA. And you can see that there's a hint that even any reduction of ctDNA is better relative to an increase. Finally, part of the relevance of all this, I think, is because it is so hard to interpret what's going on in our patients in phase 1. So on the left-hand side is a kind of unconventional waterfall from a paper by Brian Topp, work with Dinesh and others at Merck, that shows in the diamonds each individual tumor site in the context of the overall waterfall plot and the change in diameter at that site. And what you can see, as all of you who work in oncology know is the reality, is most patients actually have a mixed response, with some tumors growing and some tumors shrinking. So what can you do to help distinguish what benefit is really happening in these early stage studies? If you look on the right, this is a study from Matt Hellman and colleagues that looked across 16 different cancers in patients treated on studies with durvalumab and tremelimumab. And what you see there is the same theme that I discussed in the last two slides. So if you look at the top, the green line, those patients who had an on-treatment variant allele fraction, which is a fancy term for they had ctDNA measurable, that was 0 and didn't go up, did the best. Those who in blue had a ctDNA that was detectable, but it went down, did okay, and those in red who had detectable ctDNA and it went up, did the worst. So if you dive into that paper more, it really suggests that in patients who have stable disease, these ambiguous responses, or who have cancers where it's difficult to measure disease, this metric may help us distinguish what's really happening, at least at a qualitative level. So how do the agencies feel about this? I'm afraid that I am not sufficiently familiar with how the AMA feels about it to comment, so I'm going to focus my comments on the FDA. The FDA is really interested and they're engaged. So the report, both of these are available online. The top one is from a project that the Friends of Cancer Research did, and the bottom one is a guidance for industry. And in both of them, they really lay out, here's what we think so far, and here's what we want to know. So the FDA draft guidance really gets at the applications I've spoken about today: selection by molecular alteration, MRD, measurement of response, and using ctDNA as a surrogate endpoint. And I actually really like the language that's used because I think it's actually quite clear about where we are and where we need to go. So starting with patient selection, they say ctDNA can be used as for patient selection. So you can already do that. Their approvals support that. This one I find particularly interesting. ctDNA can be used as a marker of MRD after definitive surgery and or neoadjuvant therapy to enrich a trial for patients with high-risk disease, suggesting that they feel there's already enough data that you can actually design a trial based on ctDNA positivity and selecting for patients with that as a surrogate for high-risk disease, and indeed there are some studies being conducted that are doing that. The third bullet I think is most relevant to us. ctDNA could be used in early phase clinical trials to aid in signal finding of drug activity and to potentially aid sponsors. So we can look at this and help it inform our decisions. And then finally, and I love this language, although not currently validated for use, changes in ctDNA response to a drug may have the potential to be used as an early endpoint. Further data required. So we're not there yet with a surrogate endpoint, but they want to see the data. They're interested in us getting to that point. So to conclude, I'm going to conclude briefly on longitudinal monitoring and then overall. ctDNA does appear able to distinguish outcomes in the adjuvant setting in several solid tumor contexts, and the FDA has said it can be used to define high-risk patients more likely to benefit. ctDNA may enable assessment of efficacy earlier than tumor size change in the metastatic setting, and it may ultimately correlate better with long-term outcomes, although the data are still accruing on that point. Although ctDNA shedding varies by tumor type, current technologies are able to measure it. And for all these reasons, therefore, in certain settings, using ctDNA in early oncology studies may ultimately be cost and patient sparing. I want to underscore that when you're looking for assays and when you're reading papers, really look at what type of assay is being used. Tumor-informed sequencing is best used in settings where you want to get to a high sensitivity for longitudinal monitoring. And finally, as I mentioned, ctDNA is not yet an approvable surrogate endpoint, but the agency is very interested in this. So for the sake of time, I won't read through all the conclusions. I will mention that screening is its own ball of wax. It's a very controversial area. I'm happy to address it in the question and answer session, but for this audience, I really wanted to focus on the monitoring aspects. So thank you so much for your attention. Thanks to those who helped out with this presentation. I did borrow some slides from John Simmons and Preeti Hegde, who are at Natera and Foundation respectively, and also to all the patients and staff who enable us to study their tissues so that we can treat them better. Thank you.
Perfect timing, Alex. There's plenty of time for questions, and this is open for questions. If you do ask some questions, please identify yourself.
First. Yeah. Hi, Thomas Gerbers with Natera. Thanks, Alex. Really good overview. Very helpful to know how quickly the field is moving. I was looking, in order for it to mature as an acceptable biomarker, as an endpoint, surrogate endpoint, we need to work more on the quantification. And clearly now looking at, the crude way of saying it's not present and it won't appear, versus it's present but it's cleared, or it's present and it's not cleared. Can we say something about how much is this cleared, how much it is changing? And for that we need to get more towards also how much of that ctDNA is actually produced, which I think is like, if we can bring those two factors together, we can actually go to a much more quantifiable state of this ctDNA, and it becomes more predictable. So I guess that's where the field will be moving forward into the future. But what are your perspectives on that? Like, what else do we need to do? Because obviously we as modelers rather have the granularity in the data.
Yes, it's a great question. So I'm going to split it into two pieces. One is, what is the tumor actually releasing, or tumors? And two is, can we actually quantify that reliably and consistently? So in the first space, what is not clear, because you really can't test this, is how much ctDNA comes from, let's say, the primary tumor versus various metastatic sites. Do certain organs release more than others? That work is really in its infancy because it's so difficult to do. Frankly, it requires multiple biopsies within a given patient, so the sorts of sample sizes are just too small to say consistently. So I think we shouldn't wait for that, because I think it's going to be a long time in coming. Can we reliably quantify ctDNA intra and interpatient? Some of the assays out there, I would say yes. Several of the assays that I talked about here are what I would call home brews, where like a particular academic institution has developed their assay. But some of the commercially available assays really can reliably quantify ctDNA, so that you can look within a patient and between patients and say exactly how much ctDNA they have. Some companies like Natera assay 16 variants within a patient. They consider positivity as 2 of the 16 variants being positive, and they've done the studies of multiple samples from a given patient across time, so they've really carefully characterized the answer to this question. So I think that the assays that are going to pull ahead are those that are able to do this. The companies that make these assays realize that, and they are working on it. That being said, if you're trying to sign a study you're working on up for ctDNA, really dig into it with the assay provider, and also make sure you know which version of the assay they're using, because as you know, there's always a lag between publication and test. And so some of these companies have updated their tests in meaningful ways that you should know about before you subscribe to them. Anyway, the short answer is yes, we're almost there with, not almost, some assays are there with reliable quantification.
Okay, Johan Wallin from BioInvent. So, follow-up question to that. Am I interpreting right that you're saying that the non-tumor informed assays are good enough rather than needing to invest in the tumor informed type of assays?
It's a great question. I think the answer depends on two things. One, the context, and two, the assay. So in terms of context, in the metastatic setting where the ctDNA shedding is more, the non-tumor informed assays are enough in certain settings, lung cancer, urothelial cancer, where there's more shedding. In other contexts, you really do need a tumor informed test. So in the adjuvant setting, in general, I would advocate for a tumor-informed test because it has higher sensitivity. There's a very large asterisk around what I said, which is the tests I mentioned very early in the talk that look at methylation are evolving very quickly. So the answer I gave you today may be different in 6 to 12 months because those methylation-based tests are changing so quickly.
Mick Luby from Novartis. First of all, thanks very much for a wonderful talk. My question is, do you foresee the day when we may just use confirmed ctDNA to initiate treatment of cancer or subsequent treatment, perhaps?
I do, actually. I think in CRC, I showed you a sampling of the data. There's more out there. I think we're moving in that direction. Do we have to prove it in randomized phase 3 studies? Absolutely. But if you had asked me 5 years ago, I would have said, not in my career, but these tests are getting better so quickly, and the evidence has really been quite consistent. I think the answer to that question is going to be yes in certain contexts. It already is in ALL and multiple myeloma, so we have the precedent.
Yes, please, go ahead.
Hi, thanks for the great talk. My name is Anthony, I work at Takeda. I'm just curious, you showed some relationships for ctDNA and overall survival. How much confidence do you think we have in this assay right now to make a go, no-go decision for a pivotal study based on this assay with early stage studies?
I think for a pivotal study, it's not ready yet. I think that's what the agency is messaging us. I think where we can use it and incorporate it into the other data we already accrue is in early oncology studies where things are a little ambiguous. I think this can provide data that sheds light, but I don't think we're there yet for a pivotal study. The one exception is for selection, so for that I think we can use it, but as an endpoint, no.
So Alex, I'd like to ask a question since I think I have some time here. So the question is really in early oncology, and some of the examples you showed, the one with uveal melanoma kind of really stuck out, given the fact that there was just stable disease or even progressive disease, but ctDNA showed a very different picture. How many drugs do you think we've walked away from using tumor size change, which didn't show the reduction enough, and in fact, with ctDNA, may have actually been significant?
It's a great question, Dinesh. I think what is both promising and unnerving about this metric is that it sometimes doesn't agree with tumor size change. I think it's also helpful in diseases like prostate cancer, ovarian cancer, where defining measurable disease can really be a challenge. I mean, ultimately, for phase 3 studies, we're still looking at overall survival, so hopefully we haven't walked away from too many. But I think what you're getting at, and what I hope that I convinced you of, is I think what we may be missing sometimes is subpopulations that are benefiting that we're not discerning using the fairly blunt tools that we have today.
And on the same topic, the fact that you can actually detect it earlier is also very, very enticing. Do you think this is relevant to certain tumor types that are probably more proliferative than others, or do you think it's probably usable across the board?
It's a great question. So again, a few years ago, I would have said it was most relevant to the proliferative tumor types, but that was in part because the assays were just less sensitive. I think what we're seeing with those lead time examples is that the field hasn't really worked this out yet. The lead times just vary quite substantially depending on what assay you use. So I would hypothesize that this would be more reliable in more proliferative tumor types that shed more, but I don't think the data is quite clear on that yet, and I think it's a problem that the test sensitivity can actually help us resolve.
Thank you, Alex. I don't think we have any more. Oh, there's one more question up there. Sorry. Yes, please. I didn't see you.
Thanks, Dinesh. Thank you very much, Alex. Jeff Sachs from MSD. Thanks for that great talk. I think it's a clarification. You mentioned that you were working with collaborators at Merck. Perhaps you meant MSD while we are in the EU, in case people are confused. Two questions, really. One is, do you think the relative economy of these tests and their speed will allow them to be used for dose finding in a way that we have not been able to use imaging studies? And the second, is there evidence yet that, as with transcriptional profiling in the early days, we found that we could distinguish types of cancer that were previously indistinguishable? Is there any evidence of that?
Yes, so fabulous questions. Apologies, you're right, I misspoke. MSD was the company with which I was formerly affiliated. So let's see, starting with this second question, I think the answer is becoming yes, in the sense that the methylation profiling is suggesting there are different subtypes. When we're looking at mutations, we're sort of bringing our own biases into the process,
Yes.
Because we're testing for the things we think are important. And then just to go back here, oh yes, economy. Similar to computers, the cost of these assays is going down. There's a lot of competition in the space, which is helping that, and then the technology is also advancing, which is also helping that. My answer to your question is yes, because the cost of doing profiling on 50 patients is so low relative to the cost of making the wrong call on an early phase drug, that yes, I think we are reaching that point where we can use these data. I don't think it supplants scan data at all. I think they should be used together. But yes, I think, again, just in the last few years, we're reaching that point.
Thanks very much.
Thank you, Alex. I'd like to thank the speaker for this talk.
So great, thank you so much, I would also like to say. So I would like to introduce our next speaker, so it's Anta Kondic, and she is currently the head of pharmacometrics at Bristol Myers Squibb, and she has more than 20 years of experience in various modeling positions within the industry. And today she will talk to us about the combined use of propensity score matching and a joint tumor growth dynamics overall survival model to benchmark the efficacy of new treatments for advanced renal cell carcinoma.
It's a mouthful, isn't it?
Long title.
Good afternoon, everyone. I'm extremely pleased and honored to be here. Thanks to the organizers for inviting. I would like to say that this is a talk that represents the work of this wonderful group of people, Mayu and Amit from BMS. Then there is a group of Global Medical Affairs, Martin Balke, and then Ramon and Jonathan from Metrum. And Jonathan is here sitting on the second row, so if you have any tough questions, please direct them to him, not to me. I'm known for that. So let me just very briefly introduce the problem. I think the majority of us work with randomized clinical trials, but more and more people have to think about bridging efficacy to effectiveness, working with real-world data. The question really is, how do you benchmark studies that are in the real world? And the two studies that I will be talking about, this non-registrational data generation and investigator-sponsored research. These studies usually are single-arm studies. They have a small, relatively short follow-up. And when you try to understand the results from these studies, the question is always how to benchmark. And so the case that I will be describing to you today is how to do so, or at least how we did it, not to say this is the only way. And that very much ties up to the term of synthetic control arm, where you use existing data and you try to extrapolate, compare the patient populations, and do the bridging this way. So I would like to introduce renal cell carcinoma and some of the terms that you're going to be seeing in the slides coming forward. So the renal cell carcinoma accounts for 90% of kidney cancer. 30% of it manifests itself in terms of metastatic disease, and that is pretty dramatic disease progression after the metastasis form. There are few existing scores, risk score, prognostic scores. The Karnofsky score is basically a general measure of functional functionality, whether the patient can really function, that's between 0 and 100. Close to 100 means that the patient is not bedridden and they can function. Then you have the Memorial Sloan Kettering Motzer score, which encompasses 5 different measures. It's a discrete measure from 0 to 5, and there are various biomarkers for which you score. So if you're close to 5, you're basically pretty sick. And then similarly, there is an International Metastatic Renal Cell Datasets Consortium score, which is 0 to 4. There is some overlap between them, but they are not exactly identical. So again, people, when they get into clinical trials, they have to fill questionnaires, and these scores follow with the disease. So the treatment paradigm of metastatic renal cell has changed quite a bit in the last 15 years, thankfully. Before that, there was no chemo. The tumor does not respond to chemo. Starting in 2006 onwards, there was the tyrosine kinase inhibitors, specifically ones that target the vascular endothelial growth factor as well as mTOR pathway, have been proven to be successful, so they became the standard of care. And more recently, we have the immuno-oncology drugs, and they have shown quite a bit of promise. Pembrolizumab from MSD, nivolumab, which is a drug that I will talk about, and ipilimumab are ones that are being used, and many others. The unique thing about BMS is that it has these 2 fairly distinct immuno-oncology agents, ipilimumab and nivolumab, and one kind of targets the early, the T cells in the early portion of the proliferation, while the PD-1 inhibitors are much more later on. So it's considered that they have a fairly complementary use. And again, because they're in the BMS portfolio, they're fairly often used together. Okay, so this is the most important slide that will give you a feel for what the talk is about. So we have, I will very briefly discuss the tumor growth dynamic overall survival. I call it modeling platform. It's a joint model that we have at Bristol Myers that keep being updated with new data as it comes along, and right now it covers more than 1,200 patients. And then I will walk you through how to make predictions for a non-existing, essentially, arm for this non-registrational study. The baseline, the 2 studies that I will be talking about are listed here. The NRDG, again, the non-registrational data generation study, is a small 106 patient as compared to the registrational study, which is 214. You will also notice that it's randomized and it has more than 1,000 patients. You also notice that the EP and Nivo combination, the regimen, is slightly different, and that will become important. All right, so there are many people in the audience who work in this field, and I think I heard yesterday that machine learning is also creeping in. So I will just basically state what we have at Bristol Myers for renal cell carcinoma. We have a joint model, which means that we look at the sum of longest diameter and overall survival, and we model this together. The base model for the tumor growth dynamics, which is the sum of longest diameters, is this particular model. There are multiple others. I've authored a couple of papers with other forms, but this is the one that exists here. So you have exponential shrinkage and linear growth, and it goes to kind of asymptotic value. And then you have covariates on each of these characteristics, meaning that the baseline and the growth and the shrinkage. All of these models are nonlinear mixed effect models. And then we also model the overall survival, again, in a joint fashion. The hazard is described for this particular indication is described with a log logistic model, and the hazard then depends on the growth and the shrinkage parameters that I showed in the previous slide. And again, there are some covariates. These risk factors are very important, and they become covariates to the overall survival, and they are discretized, the risk scores here. What you see on the bottom left-hand side are some of the comparison between model predictions. These are model fits to the data, and so I will not I will not say anything more. So what this is here is taking that non-registrational data study with 106 patients, and you basically follow the tumor growth dynamics, and then you make model predictions. What I would like to point out here again is that 2018, the early, very immature data was taken in and brought into the model, and the model generated predictions that were then 2 years later compared to data that was not used for model calibration. And we would like to point out that as long as things are in the credible interval, or then we consider that the model is doing a decent job. However, when we go to comparing now across studies, right? So what you see here in blue is that non-registrational study 920, and you see that in pink is the VEGF inhibitor, that's the control for the registrational study, and then with green you see the nivo plus ipi combination that was used for the registration. So clearly the nivo ipi single arm does not do as well as what was done in the registrational study, right? It does as well, maybe even more poorly as compared to sunitinib arm in that registrational study. So the question is, why? The first question that came up is whether you actually, is the reason that there is a different nivo plus ipi regimen, or is there something else? So as typically happens when you bridge from efficacy to effectiveness, when you go from randomized clinical trials to real world, one of the first things you need to do is to look into the makeout of your patient population. And what is highlighted on this slide is that if you look at the risk scores, relatively speaking, for that very small number of patients, that they are a lot higher, a lot more people have poor prognosis as compared to the randomized clinical trial. So that basically begs the question, how would you like to do comparison apple to apple? So in order to create a synthetic arm, one needs to first of all account for the difference in the patient characteristics. And the way that was tackled was to use propensity score matching. And basically the formula is provided here. Intuitively, this formula upweighs the patients who are in the registrational trial who are similar to the one in the NRDGS, and downgrades those who are healthier, right? So we want to compare apples to apples, so we want to create, essentially, we want to see what will be the outcome for the patients who are as sick as the one in the single arm study. And when we do that, the random forest was being used to optimize these weights. They were optimized across a range of patient-specific factors which were considered important. In this graph, I would like to point out on the left-hand side you have continuous covariates, on the right-hand side you have the categorical, which include all the scores. The unadjusted weights is presented in black, and visually you will see that a lot more of these black points lie outside 0.15 and minus 0.15. What I'm showing is a standardized mean difference, which is a technique to basically account for these differences. If you see something close to 0, that basically means you've done a decent job. So most of the red triangles are in that interval, with the exception of weight, which could not be optimized. And so I just want to call this out. So then we can use these weights to then compute the Kaplan-Meier. And what you see here in green are the original Kaplan-Meier curve for the sunitinib and nivo plus ipi arm in the registrational trial. Now, once you account for these weights and you now simulate, or you look at patients who are sicker, who are more representative of what happened in the real world, you see that their Kaplan-Meier curves do not look so good, right? So that's what this was done. And then once you actually have that, you can complete the whole process by creating that synthetic arm, the sunitinib arm for that sicker set of patients who are now the weighted patients, and then account for the difference in the overall survival. So you can see that same separation, perhaps not as pronounced, but maybe the same separation between nivo and ipi, which is in green, and the weighted sunitinib arm, which is in red. So with that, I would like to conclude by saying that this was our first attempt to really to do this real-world data bridging by using propensity score matching. We think that this is a promising approach to really account for these differences. And there are multiple other indications where that is true, and that gives you a feel for how to really understand and benchmark your real-world data. And with that, I would like to acknowledge a variety of folks both at Metromed and Bristol Myers. Thank you very much for your attention.
Thank you so much, Anna, for a lovely talk. So do we have questions from the audience?
Thanks for the great talk. I have two questions. One is, in your tumor size change measurements, did you use all sites in a given patient or just the ones included in RECIST? And the other is, have you talked to regulators? Can you give us any insights about if you think there's regulatory applicability of this sort of modeling?
So I think that the ones that were used in this particular one are the ones that were followed by the RECIST. I think for a variety of different reasons. You know, we're trying to also sometimes match and predict RECIST, right? So that's and new tumor lesions is here. So we have follow-up items that really looking at the heterogeneity of the various tumors, and so that's kind of ongoing work. As far as the regulatory, I wish I can tell you it's a slam dunk, but I think that this particular one came up in 2018, maybe you know better than me, Dinesh, you know, at the FDA. I don't think it has really been discussed actively. There are efforts in the company. This one is called a SCARF project, and so it's more on the medical side than the regulatory side, but we're certainly trying to drum it all over the place. So.
Thank you.
Okay, no further questions. So thank you so much, Anna, again.
Thank you.
So then I would like to introduce our next speaker, and that's Yomna Nassar. She is a PhD student who's enrolled in the Pharmaceutics program, and she's currently in her final year. And she's conducting her research on the supervision of Charlotte Kloft at the Freie Universität Berlin.
Yeah.
So please.
Yeah. So thanks for the kind introduction. I also like to thank the organizers for the opportunity to present today. So to begin with, I think we all agree that in oncology, early prediction is highly needed, whether it is to identify response to treatment, disease progression, or even survival. And for that reason, there has been a huge interest to identify reliable predictors and biomarkers. In our work, we focused on CRP as a potential prognostic biomarker, with the aim to identify predictors of efficacy in lung cancer patients. So let's first start with CRP and what is its relation to cancer. So CRP is a non-specific inflammatory marker, and it has been associated also with infection and tissue injury. In response to inflammation, the inflammatory cytokines, of which is interleukin-6, are released, which then stimulates the hepatocytes to produce and release CRP. Also, malignant cells have been believed to trigger an inflammatory response, and that's why it has also been associated that CRP has been associated with more advanced cancer stages, metastasis, and poor prognosis. So that we can say that the elevated and chronic level of CRP reflects the state of unresolved inflammation that is associated with tissue injury when it comes to cancer growth and progression. So among the different types of cancer that CRP has been shown to be associated with is lung cancer. a disease with very high burden. It is the second most common cancer type, and it's the leading cause of cancer-related death. Moreover, almost 40% of patients are diagnosed at a very late stage, when the disease has already spread, which makes their 5-year survival not even reaching 10%. Therefore, with this background knowledge in mind, there is a huge need for prognostic markers that can predict response to treatment and also identify patients at risk of poor prognosis, for timely decision-making with regards to treatment strategies as well as possible interventions. So far, the majority of research has always focused on baseline biomarker concentration, relating it to an endpoint of interest, rather than looking into the longitudinal concentration, which would definitely have an added benefit of not only looking into the biomarker kinetics, but also taking into consideration the influence of treatment and the evolution of disease over time. For that reason, we aim to identify early prognostic predictors of efficacy in lung cancer patients, with a focus on CRP as a potential marker of inflammation, as well as on longitudinal data. The focus was not to see if modulating inflammation would be a good prognostic factor. We rather aim to answer the question of whether monitoring inflammation can reflect the disease outcome and be a potential prognostic marker. So to achieve this objective, let me first introduce you to the clinical data. Our clinical study, or the so-called CPAC-TDM study, enrolled patients with non-small cell lung cancer, the most common lung cancer type, and specifically patients in advanced stages. Those patients received first-line treatment, namely paclitaxel plus a platinum drug. The study was designed to be up to 6 treatment cycles, each 3 weeks long. Dosing was administered at the beginning of each cycle. Tumor assessment was done at baseline, before cycles 3, 5, at the end of treatment, and then every 2 months during follow-up. CRP was measured at baseline on days 1 of cycle 2, 3, at the end of treatment, and additionally on days 2 of cycles 1 and 2. Survival was monitored every 3 months afterwards. Additionally, specific to the study design, the patients were randomized into 2 arms according to the paclitaxel dose, receiving either the standard dose or an individualized dosing. The latter had additional PK samples, which were taken 24 hours after paclitaxel administration. Now, to guide you through the modeling framework, to achieve our objective, we aimed for a stepwise approach, where we first aimed to characterize circulating CRP while accounting for the influence of tumor dynamics and drug exposure. From the model, we would then derive predictors along with other observed factors that we would then aim to identify the most significant ones on efficacy endpoints, namely progression and survival. So let's first start with the first part. The figure on the left-hand side shows the coupled tumor dynamics and CRP model. To first characterize the tumor dynamics, we leveraged a previously developed chemotherapy-induced tumor dynamics model, which accounted for drug exposure as the driving force, specifically paclitaxel AUC per cycle, and also accounting for the development of resistance over time. From that model, we derived individual tumor sizes that would then inform our CRP model. For the CRP model, we adopted a classical turnover model, CRP model characterized by a zero-order production rate constant, which is split into 2 to ensure a basal level of CRP that wouldn't be perturbed, as well as a first-order degradation rate constant. We also accounted for influential factors and covariates that would influence CRP synthesis, and these were baseline interleukin-6 as the biochemical precursor of CRP, disease stage as a marker of disease aggressiveness, and smoking status, which has been shown to be associated with oxidative stress as well as inflammatory response. A decrease in the inflammatory level as well as disease aggressiveness in absence of smoking status would result in a reduction in CRP synthesis, and consequently a lower inflammatory level and a more favorable condition for the patient. Finally, a linear relationship linked the fold change of tumor size relative to baseline tumor size to CRP synthesis, such that a decrease in the fold change of tumor size to baseline would linearly result in a decrease in CRP synthesis. The model showed no misspecifications and a good predictive performance when it comes to the GOF plots and VPCs. Now that we established confidence in the model performance, we could move to the next step, which is the selection of the predictors. Based on also discussions with our clinical collaborators, we aim to identify or focus on early metrics that can provide a timely decision making. And that's why we decided to focus on longitudinal metrics derived from the first 3 cycles of our study. So first, we picked or focused on markers of inflammation, such as CRP-related metrics and neutrophil to lymphocyte ratio, taking into consideration not only the observations, but also the estimated values, as well as different metrics derived from the different cycles. We also looked into tumor size-related metrics, such as the tumor load and degree of tumor shrinkage at different weeks, as also previously reported in the literature. And finally, patient and disease-related characteristics. Now, as a subsequent step, we wanted to identify predictors that would significantly impact progression and survival. For the sake of time, I will focus on survival and I'll just touch upon the final results of progression. To characterize survival, we adopted a time-to-event modeling approach, where we would model a hazard function to characterize the risk of development of an event, in our case death, and then through the hazard function, we can convert it to a survival function that would characterize the distribution of our events over time. In our case, a Weibull hazard function characterizing an increasing risk in death over time best characterized our observations. We also identified significant predictors on overall survival to be the inflammatory level at cycle 3, CRP cycle 3, tumor load, tumor shrinkage, which was the tumor size at week 8 relative to baseline, as well as liver lesions. An increase in the continuous predictors, specifically the 95th percentile in presence of liver lesion, would result in a subpopulation having a median overall survival of only 3 months. Whereas an opposite scenario, a more favorable scenario with values of the continuous variables being at the 5th percentile, would result in a subpopulation not reaching the median overall survival even after 33 months. The forest plot here shows the impact of each of the identified predictors, where we looked into the 95th and 5th percentile for the continuous covariates and the alternative category for the dichotomous covariate. And you can already observe from that plot that there is the biggest impact is related to the inflammatory level, with almost 1 year difference between the upper and lower values. The picture was not very different when it comes to time to progression, where we identified the inflammatory level as well as tumor shrinkage to be significant predictors. Now to further explore the impact of inflammation on time to progression as well as overall survival, we decided to investigate, to run different further simulations where we would look into different levels of inflammation. The figure on the left-hand side now shows simulated profiles of the time to progression at different levels of CRP at cycle 3. And if you notice, you will see that at lower inflammatory level here, at low inflammatory level, almost at 5 milligram per liter, there isn't much impact on the risk of progression, and specifically on the median time to progression. Whereas as we move higher in the inflammatory level, we can see a worse outcome and a shorter time to progression. From that figure, we can also see that a CRP level of around 11 milligram per liter, if reached around cycle 3, would be an indicator of a worse or a shorter median time to progression. When it comes to overall survival, now the picture was a little bit different, where we could see that the different inflammatory levels evenly reflected on the survival profiles, showing an even pattern. Now, these profiles were based on simulations from our developed model. And to develop more confidence into our results, we decided to look into what our data says. We plotted the Kaplan-Meier plots of the observed events stratified by similar percentile intervals of the CRP at cycle 3. And you can already observe here in the lower panel a similar profile when it comes to the observed events, where in the time to progression, here you can see quite a difference between the low and the upper level, and with the overall survival, you can also see an even pattern. With this, I would like to summarize that through our developed framework, we incorporated the relationships between drug exposure, tumor dynamics, and the biomarker. This framework not only adequately characterized the circulating CRP concentration, but it also linked CRP as a marker of inflammation and with tumor size as a marker of disease aggressiveness. Moreover, it also allowed the estimation of longitudinal predictors for all patients, even those for whom we did not have any measurements in the study. And these longitudinal predictors allowed the identification of significant ones when it comes to progression and overall survival. Additionally, non-baseline CRP, and specifically CRP at cycle 3, was more reflective of the patient status and the patient and disease status. It was also a stronger predictor when compared with baseline concentration when they were both tested. Although one may question the specificity of CRP as a biomarker, it still held a very strong prognostic potential as a predictor of efficacy, and specifically when combined with with disease-related covariates such as tumor load as well as tumor shrinkage. The patient inflammatory status reflected by CRP reflected the risk of progression and overall survival, and can be considered as a potential prognostic marker, specifically that CRP is minimally invasive compared to other means. With this, I would like to conclude that throughout this modeling framework, we managed to identify patients at high risk of early progression and shorter survival. And then there will be a potential for early intervention. And I would like to conclude that longitudinal biomarker data should be further exploited and chosen over baseline data for more reliable patient and disease-related characteristics and predictions. With this, I would like to thank all the co-authors who have contributed to the work, specifically my supervisors, current and former members of the working group, my industry mentor, and our clinical collaborators for the support and input. I would also like to thank you for your attention. I look forward to the discussion. Thank you.
Thank you so much, Yomna, for a nice talk. So, do we have some questions?
Could I ask a question? This is a very nice talk, Yomna, and has significant application potential. I'm curious, how extrapolatable is this model? Because obviously this is done using with basis of chemotherapy, correct? And obviously now immunotherapy is coming into being with non-small cell lung cancer. And I would expect, in fact, CRP being an inflammatory marker, and sometimes you get immune activation, which is actually, you might have CRP going up, for example. So do you think it's extrapolatable beyond what the data set you've done, which is actually a very nice example, by the way. I just want to understand how extrapolatable it is.
I mean, at that stage, it's difficult to predict, I would say. I mean, probably this needs further research. However, the framework, I would say, could be translatable to other treatment modalities. However, when it comes to immunotherapy, I think it needs to be further investigated how much impact that would have on CRP. I mean, it's difficult to tell at that stage. I would say, yeah, possible, but we need definitely further investigation. I mean,
Thank you.
Yeah.
And also, I have a question. So, if I understood correctly, you are using some metrics at some certain time points. So have you also tried to use the time course of CRP or tumor size measurement and maybe do some joint modeling or simultaneous
So we didn't look into the time variation throughout the whole course, because also based on the discussions with our collaborators, they were very much interested in as early as possible metrics or endpoints or predictors. And we thought that if we rely on the whole time course, this might not be very translatable when it comes to clinical practice, and we decided to look as early as possible into metrics that can provide a reliable endpoint and prediction, I would say.
But up to that time point where you actually had the measurement, did you then look into the future to use that value, or did you up to was it 3 weeks or 3 months?
So it's cycle 3. No, we looked until cycle 3. Yeah.
Sorry, so you had a dynamic up to?
So we looked into the measurements, what they would be at cycle 3.
Yeah, already from the baseline sort of, or, yeah.
No, so it was, I mean, we looked into the baseline. We also looked into different time points until cycle 3.
Yeah, okay. I also had a question about the dropout. How was that handled?
Yes, so when you mean with the time to event modeling?
Yeah.
Yes, so we also had quite some thought into dropout modeling, whether to model dropouts or not, and we decided not to account for the dropouts for several reasons. First, I would say that according to protocol, the dropouts were not by default lost to follow up. So for the majority of them, we also had their times of progression and overall survival, so it was not like, I would say, a bottleneck or a hindrance to getting their information. And also we considered at some point perhaps a multi-state model, but then we realized that the sample size might not be so big to have a powered multi-state model. And given that we had did not have as well the time until the last follow-up, we thought that the best decision is to consider the dropouts as those who are not censored, so they all fall into the same category, whether they have the endpoint or not.
Okay, I think, so you didn't, in the simulations, everybody could survive until the end. Okay, other questions from the audience? Yeah. So thank you so much, Yomna, for very nice talk.
I think we'd also like to just thank all the 3 speakers for a wonderful session.
Yes.
I think as well. So thank you.
You should. Thank you. And the audience.
So don't leave yet, because we've got a presentation by Wei Gao around ACoP. There she is.
Thanks, Dinesh, and the PAGE Organizing Committee to give me a few minutes to talk about the ACoP-related activities that we are hosting this year. So about ACoP, we offer more than hosting ACoP, the conference, including access to the Journal of PKPD and many more, as you can see on the slide. Okay. So ACoP is governed by laws as well as the Board of Trustees. So most of us are here today, including CJ, our president, VJ, president-elect, Brenda, our past president, and many of us. So if you see us, please say hello, and we're very happy to tell you more about ACoP, the International Society of Pharmacometrics. So ACoP this year, so you will be held at early November this year at National Harbor, Maryland. We have excellent keynote speakers as well as state-of-the-art speaker, many scientific sessions, and including special sessions. And we also offer a lot of free tutorials and workshops at ACoP. If you are interested to learn more about ACoP this year and for registration, please scan the QR code as shown on the slide. Okay, so we also are very happy to announce ACoP is co-hosting a public workshop with the FDA. So this is 2 days event on quantitative methods in dosage optimization of oncology products. First day, we focus on the modeling simulation to evaluate effects of intrinsic and extrinsic factors at the FDA campus. By the way, both days are open to public, offer both in-person and virtual attendees. However, we do require you to register. It's selling out very quickly, so please scan the QR code again to register. So back to the actual event. So the second day of this workshop would happen at the same hotel and actually the resort and the convention center at National Harbor right after ACoP. So it will be the same Thursday of that week. As I mentioned, this is co-sponsored by ACoP and FDA. So you see the co-chairs from FDA, Stacy Short and John Liu. CJ and myself from ACoP are the co-chairs as well. So we are actively working on the agenda. The information will be soon available. Again, please scan the QR code to learn more about the workshop as well as do the registration. Last but not the least, we do have our booth here at Page. Our executive director, Jennifer Monroy, is here at the booth. So please stop by and learn more about ACoP as well as the activities I just mentioned. Thank you.
So thank you so much, Wei. We look forward to ACoP this year, and we will meet back here again at 4:55, so 5 minutes to 5. Thank you so much.